All right, good afternoon. Thank you for joining us for our afternoon session on pediatric and adolescent STI and HIV prevention interventions. So this afternoon we have a really excellent panel of speakers and for the discussion afterwards. So I'm really glad you've joined us. Can I just have a show of hands? Who in here looks after children or adolescents? Oh, okay, pretty much all of you. Fantastic. Who's from Asia? Shout out some countries. Everyone's from Asia. Who's come from Vietnam, Laos, Cambodia, Malaysia? Oh, fantastic, someone from Malaysia, great. Myanmar. Oh, okay, great, welcome. Is everyone else from Thailand? Philippines, oh, sorry, didn't mean to miss you out. Welcome from the Philippines too, fantastic. So we have 3 speakers today and we're going to have a session after this discussing about healthcare models for adolescent HIV healthcare delivery. I hope you can stay for all of them. Our first speaker, I'm very pleased to introduce to you, is Colonel Eric Garges. He will be speaking to us about STI prevention and treatment in adolescents and young adults. Some of you may know him because he is an army physician and is based at AFRIMS in Bangkok, Thailand. His research focuses on infectious diseases and STIs, and he's done multiple studies over the years, collaborates closely with the World Health Organization on global partners and antimicrobial resistance surveillance and countermeasure development. He's protocol chair for several NIH-sponsored clinical research studies, and has worked on seeking licensing for the first gonorrhea vaccine. He's previously also worked in Kenya, leading the Division of Global Public Health at the Uniformed Services University, and served as Research Area Director for STI Research at the Department of Defense Infectious Diseases Clinical Research Center in Bethesda. His medical degree is from Boston University, and he also has training in public health and holds master's degrees in public health and tropical medicine and hygiene. So welcome to Colonel Garges.
Hopefully it's not going to be the same. All right, I'll go with it and we'll see what happens. First, I'm Colonel Eric Garges from Rare AFRIMS, and I'd like to thank the organizers for the invite and the scientific community for seeing the value of this type of talk. A couple of disclaimers up front. I'm neither an adolescent specialist nor a pediatrician, but as you've heard, I've done most of my adult career looking at STIs in militaries and defense forces, which is roughly mostly the ages of 17 through 24, so I kind of consider myself an adolescent medicine groupie. I just want to put out there that I'm a Farang provider talking about issues of STI care in Asia, so there's some inherent bias there, and my apologies for that bias, but that's what you get. And then finally, the views here are my own and don't necessarily represent the views of those that claim me at my institution. So I want to start by grounding us in the global picture for STIs. So most people know and recognize that STIs are on the rise globally and have been for about the last 20 years. Unfortunately, that probably means that we normalize that and don't really stop and consider what it means that STIs have continued to accelerate across the globe. This isn't confined to a single age group or a single risk factor, but I will say adolescents and young adults share a disproportionate burden of this disease. So if you look at age stratified data like we have here on the right, and this is representative data. It's from WHO, obviously, Western Pacific region. But if you take any region or anybody's STI data, it's essentially going to look the same way. And when you get to age 10 to 14, you start to see something, and then all of a sudden you see this rapid acceleration, right? This isn't a gradual increase. This is an inflection point that needs to be a primary public health target, right? This change, this increase, isn't explained by behavior alone. It reflects this convergence of biology and sexual network structure and health systems that adolescents don't want to interact with or have anxiety around interacting with, and that kind of leads to a perfect storm for STI acquisition. And this has consequences, across time. If you take one specific example, I'll take an HIV example from the Philippines. in the last couple of years, there's been a rapid increase in HIV in 15 to, I think it's like 22-year-olds. This doesn't reflect this radical change in behavior among that age group. It's the same problems, it's the same challenges and systematic constructs that you have in other places. But what's happened in the Philippines is that you've dropped this on top of a rapidly expanding underlying HIV epidemic, and this is kind of what you get as a unique public health challenge. So the key point here, again, adolescents aren't just another age category. It's a period when risk accelerates. So when we talk about prevention in adolescents, really what we're talking about is whether we intervene early enough and in the right way to change this trajectory, because this trajectory influences what's going to happen with STIs over the next 20 or 30 years, right, for those individuals. Okay, so for the providers in the room, some of this is review. Why are adolescents a little different, and why does this matter? First off, adolescents are more biologically susceptible. You know, their genital tract and mucosal immune system are still maturing. That increases their vulnerability, so if they are exposed, they're more likely to become infected. There are strong social and structural constructs in place around adolescence. We talk about stigma. Dr. Tanya Weed eloquently described stigma and HIV in this population this morning. But stigma around youth sexuality, things like concerns around consent and confidentiality, fear of disclosure in adolescence, fear of engaging even with health systems for testing and treatment, all those influence the difficulty in being able to manage STIs in this population. Adolescents and young adults are embedded in these kind of high-dense, high-prevalence sexual networks. So infection spreads very efficiently. Diagnosis tends to lag behind. So in networks, you get onward transmission in youth and adolescents, oftentimes before identification and treatment has caught up, right? It's one of the reasons why these networks exist. And then finally, we have what I like to call a digital disconnect. And this isn't limited to adolescents, but in adolescents and young adults, relationships today are forming quickly through social media and through apps. But again, the health systems respond slowly. And for adolescents, where the health system responds isn't in that digital space where they're used to interacting in the places where the relationships form. So the key point here is that these factors don't happen in isolation. They converge during adolescence, again, to generate this perfect storm that drives the acceleration of STI risk. It's also the reason why STI prevention programs that are designed by adults, making assumptions around adults, really don't apply and don't work in adolescents, which is one of our primary failures. Okay, so I'm going to talk about 3 sets of tools. I'll talk about vaccines, I'll talk about antimicrobials and behavioral interventions. Each works on its own, but the real impact is when these things come together. It's kind of the you are here right in the middle. When we engage in a way that we can communicate effectively with adolescents and that we can use biomedical tools within that space and get these things to all work together. And I'll start with vaccines because it's kind of the space that I'm in. And I'm going to pretend like we have STI vaccines because I'll talk about it a little bit. We're on the cusp of a time when I think we're going to have more vaccines available. But currently, HPV vaccine is the model. It's our only good example, but it's also probably the most effective STI preventive countermeasure that we've ever deployed, right? It prevents infection, it prevents cancer, it works extraordinarily well if it's given at a time before exposure. And adolescence is, of course, the optimal window for this. Here in this region and across Asia, it's deployed in school-based programs, which are the most effective way to deploy these vaccines. This is different than what we do in the US and in much of Europe, and that highlights some differences in uptake that I'll talk about. But what's striking about HPV vaccine is that the efficacy is really good, but the primary problem is, of course, uptake. So even with school-based programs, you have operational issues like kids being out of school or uneven application of programs, probably more so in the West, but it's a problem looking forward. A lot of the success of the vaccine has been based on it marketed as a cancer vaccine, not as an STI vaccine. So if we move into an era when we have new gonorrhea vaccines or chlamydia vaccine or syphilis vaccine, Are we prepared to deploy those as STI vaccines, and is uptake going to continue to be a problem? Those are the issues we need to think about today when we're thinking about STI vaccines. Okay, so this is my view of the current STI pipeline. For those taking pictures, there's one error here, which is mildly amusing to me, and it got updated, but I'm on a different version. And that is, under gonorrhea, it's got phase 2B to 3, 1. That should be 4. I'm the protocol chair on one of those, so I think I put 1 just being excited about getting it on the slide, and as it turns out, there are a handful of them. But this is kind of a rough list. It's probably not a complete list. It's what I put together based on review of available data and conversations with colleagues of mine at NIH. One important thing to note is that adolescents are the intended target for almost all of these, right? Because we need these to be deployed before exposure happens and to be able to reduce forward transmission within networks, to impact the network. But across the 6 major STIs here, the maturity of the pipeline varies. So gonorrhea is the first one, right? There are multiple candidates in clinical development. There's growing interest in the meningococcal OMV vaccine, 4CMNB or GSK's Bexsero. Again, there are 4 or 5 ongoing phase 2B, phase 3 clinical trials. The data for those will probably be available all around the same time, later this year, early next year, and we'll have our answer for that. There are other vaccines that are already in human trials that are standalone gonorrhea OMV vaccines, not based on the meningococcal OMV. And then there are also non-OMV GC vaccines that are making their way into clinical development. So the vaccine space for gonorrhea actually looks pretty good. 50 years of development, and I think we're finally getting somewhere. Chlamydia and HSV kind of follow that a little farther behind. There have been some successes followed by some failures in those pipelines in the last couple of years. But there are candidates in early development, and I think importantly a clear path forward for both of these STIs that didn't exist 5 to 10 years ago. So there's reason to be hopeful about a relatively near-term future that has vaccines for chlamydia and HSV. For other STIs like syphilis and trick, the development remains earlier, and there are clearly longer-term challenges. There's not a lot of investment and interest in a trick vaccine. And then syphilis vaccine development, despite lots of trying, still suffers from developmental challenges. It's really hard to make a vaccine against syphilis, right? So we're a ways off from that. The takeaway here is that vaccines aren't imminent for all STIs, but adolescents are already the focus. It's the target product profile already for most of these vaccines. We just need to make sure that we know how we'll use them when they do become available. Okay, so I'll move into antimicrobials a bit. So antimicrobials, as we all know, are essential for STI control, but they're a bit of a blunt tool for prevention. So treatment does act as prevention by shortening infectiousness, but only briefly. So unlike in HIV, where you have treatment as prevention, this doesn't greatly impact network dynamics for STIs. And then, of course, we have high reinfection rates, and we don't do a good job of partner therapy. So really, we're not going to be able to treat our way out of adolescent and young adult STI problems. We've got new prevention tools like doxycycline post-exposure prophylaxis, which is great and effective. And we've got HIV PrEP, which is great and effective and actually has quite a bit of data. Some of the limiting things here, particularly with DoxyPEP, is there's limited data in adolescents. There are clearly issues with resistance, which I'll highlight when you're talking about use with gonorrhea. And both of these still involve kind of engaging in programs, right? These are compliance dependent for the most part today. Compliance dependent, require a bit of monitoring, so they still require users to engage with the health system, which we've already highlighted as one of the key challenges with this population. Treatment realities, current guideline-based therapy is still largely effective. We still suffer from having to do syndromic diagnosis. and have lack of specific diagnosis kind of at the end user, and that continues to plague the landscape. There's some things in the future that target those particular problems. But resistance is still going to be a problem, particularly with something gonorrhea, which is my go-to example. Even in a landscape where we've got new drugs available, drugs on the horizon like zoliflodacin and geptidiacin, the modeling is still clear that those will buy us a few extra years of time, but a vaccine is probably going to be the only solution that's going to work at scale, right? So antimicrobials for prevention are necessary, but they're not sufficient. Durable prevention using antimicrobials, again, requires treatment, it requires early screening, it requires partner services, and again, requires systems that adolescents will actually use over time. All right, so we'll move a little bit more out of my comfort zone, but this is where I think the data and talking about what clinical trials actually say becomes really important in this space. And so we'll talk about what's the data around behavioral interventions. And when I say behavioral interventions, I'm talking about communicating things that actually lower STI risk. We're not talking about transfer of information. I come from an organization that still does things like gets people in a room and gives them a condom and a banana because they assume that the STI problem is that people don't know how to use condoms. That's not what the problem is, but we still think that basic information will solve the problem. Most in this room probably know that that's not effective, but it does still happen. What we need are the interventions that determine if risk reduction behaviors and biomedical tools actually get used in the real world. So the first one here is there's good clinical trial data on intensive clinical counseling, and this has made its way into the WHO guidelines and the US CDC guidelines. This is skills-based counseling delivered in clinic. And what does high intensity mean? In these trials, high intensity means 90 minutes to 2 hours, doesn't have to be at the same time, of skills training in an individual. That doesn't just show change in behavior, and it shows reduction in STIs in those individuals, particularly bacterial STIs. The problem with this, the data's good, but this doesn't scale very well. As a healthcare provider, if you tell me I can address this problem, but I have to invest 2 hours in every 16-year-old that I see, it's a challenge to scale that, right? But the data's there, and this is good clinical trial data that's made its way into guidelines. Similarly, but probably a little more practical, is small group skill building. So this is skills-based counseling delivered in clinic. It doesn't have to be delivered by a provider. This is 4 to 5 sessions that can be around condom use, negotiation, effective communication with partners, right? Things that shape real-world exposure. The other one here is technology-enhanced follow-up. This doesn't surprise anyone given my discussion around this technological divide. This is using technology to interact with your patient, and whether that's around completing therapy, whether that's around coming back in for repeat screening, using telehealth, using social media, using your community health workers and nurses to increase that interaction, gets individuals into the healthcare network, and there's decent clinical trial data around that type of intervention. There are a few more. Youth-friendly services. This is one that actually has good clinical trial data from here in Thailand, here in Bangkok. All the discussion around stigma this morning is not going to surprise anybody that things like addressing confidentiality concerns, having non-judgmental staff, spaces that are acceptable to youth and teens, and even young adults, things that lower the barriers to increase testing and treatment and retention in programs. That's what's important here. And there's clinical trial data that programs that specifically address those issues will not just change behavior, but will actually lower STI burdens, bacterial STIs in these cases, burdens in the population. I feel kind of funny saying this in front of people. People do this exceptionally well here. There are a number of programs where we see this at like IHRI. My colleagues at Love Yourself in the Philippines excel in this space. They're exceptional. So it's no real surprise, but it has to be a focus everywhere where you're trying to implement care programs to reduce STI in adolescents and young adults. Partner notification, again, trying to address the network. Improving partner treatment helps break those reinfection cycles by directly impacting the network. Where it's legal and feasible, doing expedited partner therapy, there's really good data around expedited partner therapy as a way to break those cycles, and particularly in studies looking at chlamydia, expedited partner therapy has shown to reduce chlamydia burden in populations. The one thing I'll say, again, we're not necessarily talking, we're talking programmatically, but it's not a funding issue. There's also a lot of data around cost effectiveness of things like expedited partner therapy. So from a programmatic perspective, it's a good dollar spent. So I'll throw that out there as well. And then the last one is structural interventions. So, this is it's a little more abstract, but it's keeping programs that keep kids in school, things that reduce economic vulnerability. The idea is that this lowers exposure to higher risk sexual networks, right? And so reduces the influence of higher sexual networks on primary and reinfection in adolescents. It's kind of context dependent, but where these programs work, they work pretty far upstream. So the data from studies is largely in HSV2, but there's no reason to think that it probably wouldn't also apply to other STIs. So the unifying theme is that most of these interventions act on systems and networks and don't really require personal motivation. All right, so a couple of quick cases just to reinforce what we're talking about here. So this is an example, a 17-year-old female seen in clinic, no HPV vaccine, and she comes in with recurrent chlamydia and doesn't want to disclose her partners. So just take a minute, think about the things that we've thought about, and what do you think some of the failures are here, or what are the targets that could be addressed to help to improve her health and to change her trajectory for STIs? What gaps do you see? Well, the first one's obvious, the HPV one, I'll just call it out quickly, right? HPV vaccine works best if it's done before exposure. She's missed the boat there. Providing her HPV vaccine would be a primary intervention for her. The second is her reinfection. So without effective follow-up and partner services and repeat testing, we're only providing her brief protection when she comes in for her reinfection. So we're really failing her in future prevention. Similarly, if she doesn't want to disclose partners and she's not comfortable and she doesn't trust the system, we're also not providing a care system that changes her trajectory over time, right? This isn't a healthcare failure. She comes in, we treat her, she gets better. From a healthcare provider, I've done my job. It's all well and good, but we're failing her, right? We're putting her on this trajectory. Second case, 19-year-old on HIV PrEP with recurrent gonorrhea asking about doxycycline post-exposure prophylaxis. So on the face of it, this looks like a win. He's engaging in care, he's asking good questions, he's on HIV PrEP, right? So this is on the right path. What do you see, or kind of what do you think about this? With him, this exposes some of the limits of our evidence about biomedical countermeasures, right? So doxy-PEP has strong data in MSM in adults, has limited data in adolescents, and for this guy who's got recurrent gonorrhea, this does not solve his problem, right? You're unlikely to have doxy-PEP prevent gonorrhea, particularly in Asia where the TET gene and tetracycline, doxycycline resistance is essentially ubiquitous, right? So he also has the same reinfection problems that we saw in the other person. He's not necessarily getting good preventive care in his network because even though he's on HIV PrEP, which is great, he keeps coming back with gonorrhea. So the takeaway here is that biomedical tools aren't going to be able to replace systems. We have the same kind of problem with this individual. Without appropriate use-centered delivery and monitoring and safeguards, you're not going to reduce all of the STI burden with biomedical tools alone. So let me kind of pull all of this together. Adolescents require specialized approaches, right? This is a period when biology and social context and sexual networks converge and STI risk accelerates. We have some tools, we've got some biomedical tools, we've got good therapy, We've got a vaccine and some others that I'm hopeful we'll have in the near term or in the future. We've got behavioral interventions that can be effective if applied appropriately. The evidence is clear that interventions that target mechanisms, access, trust, community, network exposure, these things outperform mechanisms that require changes in personal motivation. That's what the data says. But if you go back to that first slide and you look at what's happening with adolescent STIs, we have a timer. Perfect timing. What's happening with adolescent STIs? We just don't do a good job with prevention in this group, right? We are largely failing globally adolescents in terms of prevention. And so I don't think that adolescents are failing our prevention programs. I think our prevention programs are failing adolescents, right? So for better outcomes, we need better systems. And the question is, how do we get there? How do we get there for the group? So I'll leave you with that. Again, I'd like to thank the organizers for the invitation. And I guess I'm out of time, but otherwise I'd be happy to take some questions.
Thank you so much, Colonel Garges. We have time for one question. Does anybody have a question before we go to our next speaker? Looking not at the moment. Thank you so much. Thank you.
Thanks, Nat.